Hi everybody, I am Dr. Chandrasekhar, Director of Shoulder Surgery, Kim Sunshine Hospital, Begumpet, Hyderabad. Today I am going to discuss about clinical examination of shoulder. Clinical examination of shoulder is less often taught, unlike hip and knee examination for the residents, and less well understood by the residents. But it's a very easy examination provided you follow a proper pattern. There are certain points to be taken in history, certain points to be taken in inspection and examination, and there's some special tests. Once you put together all these tests, you can easily arrive at a diagnosis. In fact, most of our diagnosis we make in shoulder pathology is by clinical examination. MRI scans and X-rays are the only kind of for confirmation basis. So, as all of you know, the shoulder joint is made of 3 joints, and that's what it is. The glenohumeral joint is the thing which you know, but you know that the acromion joint and sternocleidomastoid joint are also contributing to the movements of the shoulder. And there is the scapulothoracic articulation. It's not exactly a joint, but it's like a bursal thing, and which will add to the movements of the glenohumeral joint. In fact, out of 100 degree of elevation in a patient, 120 degree will be contributed by the glenohumeral joint, and 60 degree will be contributed by the scapulothoracic movement. All these joints, they won't work in isolation, but they work in tandem along with the other, and then give the full movements of the shoulder. Coming to shoulder examination, the first thing, as in any examination, it goes into history, then followed by inspection, then followed by palpation, then you check the range of motion of the shoulder, and then muscle testing, and then it ends with neurovascular examination and some special tests. Coming to the history, first thing is that you should know the age of the patient, because the pathologies vary with the age of the patient. For example, osteoarthritis of the shoulder is common in 60 plus age group, and frozen shoulder is a commonly seen problem in 30 plus to 50 plus age group, and rotator cuff pathology again is a 60 plus age group pathology. So, age of the patient is very important to give us an idea about the pathology. And then you should know the chief complaints, whether the pain, whether the stiffness, whether the weakness, etc., and what are the functional limitations of the particular patient is facing, because you have to design your treatment as per the patient's functional limitation. So, for example, a patient is a sports person, and then he says that he cannot throw a ball with force, then your treatment should focus on giving the patient back the ability to throw a ball. For example, patient is a desktop worker and he wants to just do desktop job without pain, probably should tailor your treatment to suit for his functional demands. Now, in the history, the first point is pain, and we will tell you what points to be noted in pain, and then the other thing we should focus is weakness and any history of instability like dislocation, subluxation, etc., or pain while throwing, overhead throwing, etc., and then stiffness, and then catching or pseudolocking, and loss of movement and crepitus. They are the various things which you should ask in history. Coming to the pain, we should know whether the complaint is traumatic in incidence or it's insidious, which the pain has developed gradually or after following a trauma. Because this gives a history of important points, like for example, it is a traumatic thing, it could be a fracture, or it could be a rotator cuff tear, or it could be a labral tear which happened due to a trauma. For example, the pain is due to insidious onset or slow developing, that could be frozen shoulder or a degenerative rotator cuff tear or an arthritis condition which is developing over a period of time. Coming to the progression of the pain, if the pain progresses very quickly, then the pathology could be a rotator cuff tear pathology. If it develops, progresses very slowly, it could be a frozen shoulder which takes many months to gets worsened. And then radiation of the pain, usually shoulder pain, most of the patients they complain near the deltoid insertion, not exactly the joint, glenohumeral joint, but not near the deltoid insertion. There is one frequent point, which is asked by the patient. The patient says, my pain is not in the shoulder joint, but it's in the arm. But you have to explain to him that the pain radiates, the shoulder pathology, the pain radiates into the arm, especially near the deltoid insertion. And sometimes the pain can radiate into the elbow and forearm, but usually shoulder pathology pain will never radiate into the fingers. If some patient complains that the pain is radiating into the fingers, then you should think of more like a cervicobrachial neuralgia or other pathology rather than a shoulder pathology. Or sometimes the patient can have a combined pathology, wherein the shoulder pathology is giving pain in the arm region, and the cervical pathology or some other pathology is contributing pain to the forearm and fingers. But in shoulder pathology in isolation won't give any pain to the fingers. And we should know about aggravating and relieving factors and what aggravates the pain, whether it's overhead throwing aggravates the pain, or whether it's nighttime pain, or what are the factors that relieve the pain. Coming to rotator cuff tear, the pain usually with overhead activity, and nighttime the patient have pain, and there is usually the patient complains of weakness that he cannot lift weights, and whenever he tries to lift weights he will have pain. Coming to adhesive capsulitis or frozen shoulder, the patient along with pain he complains of stiffness that he cannot reach his back while bathing, or cannot bring out his wallet from the back pocket, something like this. And then he complains of severe night pain. Most of the patients with adhesive capsulitis, they complain of severe night pain, and they complain to you that they cannot sleep in the night. This is one important point to be noted in adhesive capsulitis. And the pain usually happens in the end range of movement. Coming to slap lesions or superior lateral tear anteroposterior lesions, the pain the patient usually complains at the posterior part of the shoulder, and usually the pain is at overhead throwing position. And remember that in slap lesions, the patient will not complain of pain while sitting with his hands on the side or while sleeping, etc. It's mainly due to overhead throwing, wherein there is a kind of micro instability which will cause pain. And usually they say that while trying to throw overhead, they will have sudden weakness and sudden pain, and they feel as if the arm has gone weak. This is called dead arm syndrome. And coming to osteoarthritis of the shoulder, though it is less common than knee, it is in fact it's not as rare as it was originally thought, because nowadays with better shoulder pathology, better understanding of the shoulder pathology, and better imaging modalities, and better knowledge about the shoulder problems in general orthopedic community, we are picking up more and more osteoarthritis of the shoulder. In these patients, like any osteoarthritis, there is rest pain or pain with movements, and in severe cases where the patient can complain of pain during night also. Coming to instability, somebody complains of dislocation or subluxation of the shoulder, we should know, the first point we should know is whether it is a traumatic incident or a traumatic incident. For example, if the patient says that he had a fall from bike and then dislocated the shoulder, or he fell down while playing some basketball or kabaddi kind of match and then fell down and he dislocated his shoulder, it is a clear-cut history of trauma. But if a patient says that he dislocated his shoulder while sleeping in the night, just trying to put on a shirt or something, then usually we should suspect some other causes rather than a traumatic causes. But again, sometimes we do come across patients who had some injury earlier which led to the labral tear without causing frank dislocation, but over a period of time, either due to progression of the tear or due to sudden overhead activity, the patient can develop a dislocation at a later date with trivial movement. So sometimes this sounds like a traumatic event, but if you try to inquire the patient more and more, they could be able to recollect some kind of traumatic event in the past. So you should also inquire about recent trauma and also about any previous injury to the shoulder which are significant. And then coming to instability, we should ask for how did the first episode of dislocation happen and what exactly caused it, whether it's fall from a bike while injury doing a sport, or fall in some domestic places, etc. And then sometimes it could be due to some kind of a fight or violence. So again, we should know the amount of severity of the injury that happened during the first dislocation, because the severity of the injury tells us that, for example, somebody going on a tour at 100 kilometers per hour and then suddenly falls down and injures his shoulder, that means it's a high severity injury. And sometimes somebody falls in the home with sleeping on a wet floor or something, you can dislocate. But again, the severity of the injury is less. So with the severity injury, usually can understand that the severity of the damage in the shoulder, and probably this will guide us into applying the treatment modality. And how did the first episode was reduced, whether reduced by the patient himself or is reduced by a doctor, or whether the reduction was done under anesthesia or not. This is something which you have to note down. And then, and what treatment was given at that time during the first episode, whether he was immobilized or not immobilized, etc. And then we should note down how many episodes of dislocation have happened till the time the patient met you, whether it's 10 dislocations, 20 dislocations or 50 dislocations. Because the frequency of dislocations, the total number of dislocations tell us that the higher number of dislocations, the more amount of pathology or damage in the glenohumeral joint, or more amount of bone loss on the glenoid, etc., which will come into later in the treatment part. But we can tell that the more amount of dislocations, the more amount of damage in the glenoid and labrum, and probably the treatment modality changes for that particular patient. So, for the frequency of dislocations and the ease of reaction and sleep dislocations have to be asked, so that we can understand or we can assess the prognosis of this patient, and we can change the plan of treatment as per the expected amount of damage in the glenohumeral joint. And also, we should ask the patient in which direction the shoulder is dislocating. If the humeral is coming out to the front, or if the humeral is going to the back, because you know that you can have dislocation to the posterior side also. It's called posterior instability. Even though the most frequent thing is the anterior instability, sometimes the patient can dislocate the humeral head posteriorly, what is called posterior dislocation or posterior subluxation, which is commonly seen in epileptic patients, in electric shock, or sometimes due to trauma. So, this is one important thing which you should ask. Coming to the history, the next point what we should ask the patient is stiffness. Stiffness can happen in three settings. Number one is primary adhesive capsulitis, or what we call as frozen shoulder, and it also can happen after an injury, it's what we call a post-traumatic stiffness. And then sometimes the patients can have stiffness along with concomitant rotator cuff tears, what we call the secondary frozen shoulder along with the rotator cuff tear. So, stiffness is an important aspect, and though the most common pathology with stiffness is frozen shoulder, it can also happen post-traumatic or post-operative conditions also, or sometimes associated with rotator cuff tears. This is called secondary stiffness. Coming to weakness, somebody says that they cannot lift the shoulder is weak. So, we have to further ask some certain questions to the patient. We should ask whether he cannot lift the shoulder because of the pain he is having. So, if the patient says it is because of pain he cannot lift the shoulder, so it is difficult to assess whether it has any weakness, because the pain overshadows the weakness, any kind of weakness in the muscles. So, the second part is neurological. Any kind of neurological problems can cause weakness, and if it is neurological, we should ask about any history of numbness, tingling in the hand, in the forearm and the fingers, especially in cervicobrachial neuralgia kind of situation, where the patient can have radiating numbness and tingling to the hand and fingers. The weakness could be due to a muscular tendon insufficiency, wherein a tendon tear like supraspinous tear, infraspinous tear, or subscapular tear can cause weakness for the patient in doing overhead activities. Now, other conditions like catching or pseudo-locking or loss of movement and crepitus, they are not very specific, but they can happen due to subacromial bursitis or subacromial impingement, wherein the subacromial space can give you some kind of crepitus and then some kind of catching sensation, or it can happen due to partial tears or rotator cuff tears, partial or full thickness rotator cuff tears. And then loss of movement is a part of stiffness. And crepitus can happen, as I told you, due to subacromial impingement, or it can also happen due to osteoarthritis conditions, wherein the osteoarthritis, the arthritic joint can give you some crepitus sounds just like knee crepitus. So, coming to the general examination of the shoulder, we should see for the build of the patient and axial alignment of the patient and lumbopelvic stability, and then generalized laxity. The role of axial alignment and lumbopelvic stability in shoulder is especially important in overhead sports persons, because the concept of this force generation chain or kinetic chain is that, for example, somebody is running and throwing a ball like a fast bowler in cricket, he generates the energy from his lower limbs by running, and then he transmits this energy through the kinetic chain through the core of the body and through the spine and to the scapula and the shoulder and glenohumeral joint, and shoulder transmit this force into the hand, and the ball will release the ball, and the hand will release the ball at the end, and transmitting all the energy that was built up during the running of the person when the player has run and developed this kinetic energy, and this energy will be transmitted into the ball, and this ball will be thrown at a high speed. If somebody has some problems with the alignment of the lower body and lumbopelvic stability, and this imperfection can cause some less inefficiency in transmitting this energy through the kinetic chain, and then these sports persons tend to generate more forces on the shoulder to compensate for the inefficiency of the kinetic chain, and then they put undue stress on the shoulder, and they tend to develop some kind of pathologies in the long term. Now, so in these patients, it is imperative that you have to correct this lower body or lumbopelvic malalignment and instabilities first before treating the shoulder, because that is the primary etiology which affected the shoulder in the long run. Examination for generalized laxity is important, especially in case of instability, wherein you should check for the Batten score, and the higher the Batten score, the chance of multidimensional instability is higher, and then the higher the Batten score, we should think of changing the surgical procedure in patients with traumatic instability also, because doing a regular procedure in a traumatic instability with hyperlaxity can cause higher failure rate. So, we should take generalized laxity into account, especially while dealing with patients with shoulder dislocation. And examination of neck is an integral part of examining the shoulder. We should never examine a shoulder without first examining the neck, because most of the times there is a neck pathology can mimic a shoulder pathology, and then sometimes the neck pathology coexists with the shoulder pathology. So, we should examine the neck first, then only we should examine the shoulder, and I cannot emphasize more on this point. So, as we say, every shoulder is connected to neck. So, without examining neck, don't examine the shoulder. Look for it's not necessary to be a detailed examination, but you can examine simply the paraspinal tenderness, you can examine for the neck range of movements, and you can examine for doing the Sperling sign, wherein you rotate and compress out the neck and reproducing the radiating pain that happens in a cervical spondylosis. So, these three things are sufficient to examine the neck before you going to the shoulder proper. So, just check the range of motion, and then check the paraspinal tenderness and check for the Sperling sign, and then go for a shoulder examination. Coming to the examination of shoulder, when you begin examining the shoulder, always start examining from the back of the patient, because this gives you an opportunity to see his scapula, because most of the times when you start examining from the front, you start examining from the front and you finish examining from the front, and you will miss seeing the back of the patient and you miss examining the scapula, and then there are certain pathologies in scapula can be missed, and which we can falsely ascribe to the glenohumeral joint, and then the treatment can be wrong. So, always start examining the patient from the back, just spend 1 minute on this and then turn the patient to the front, and they can proceed with the examination of the front. So, when you look at the scapula, you should examine for any winging of the scapula, drooping of the scapula, and especially any wasting of the infraspinatus muscle, isolated wasting, because there is a pathology in which called the sphenoglenoid region. You should look for any isolated wasting of infraspinatus. In this isolated wasting happens in patients with compression of the suprascapular nerve in the sphenoglenoid notch region, and this leads to infraspinatus weakness, wasting, and usually once you see isolated infraspinatus wasting, you should look for this pathology specifically. And then scapular dyskinesia, which can happen primarily due to the pathology in the scapula itself, or due to secondary reasons, secondly due to some pain in the glenohumeral joint, you can have dyskinesia. So, you should rule out a primary scapular dyskinesia before going to examine the glenohumeral joint proper. So, ask the patient to do forward elevation in the scapular plane and lateral elevation in scapular plane, and check for the position of the scapula by palpating the tip of the scapula at resting position and while doing range of motion movements. Now, coming to the palpation, there are certain points of palpation. We start for looking for tenderness, coracoid process, and then coracoid process pathology sometimes can have tenderness due to a kind of epiphysitis of the coracoid in skeletally immature adults, skeletally immature children playing overhead sports, and then you can have coracoid tenderness in adhesive capsulated patients, and then you can have coracoid tenderness in pectoralis minor tightness, etc. Coming to acromioclavicular articulation, it is an important test that you check for joint tenderness at the AC joint, because this is one pathology which can be diagnosed by only 2 points: direct tenderness on the acromioclavicular joint and cross adduction. So, many times if you take an X-ray or an MRI scan in a person with 40 plus age group, you can see AC joint arthritis, but it is only radiological, it is not a real AC joint arthritis. So, if you want to diagnose that the patient has AC joint arthritis and this clinically is relevant, then you should prove it by direct tenderness on the AC joint and then pain during cross adduction of the patient. So, always look for tenderness on the acromioclavicular joint. And tenderness in the acromion sometimes could be due to os acromial, which is unfused acromion, then it could be fracture of the acromion. And again, tenderness of the greater tuberosity, though fractures of the greater tuberosity can be seen on X-ray, sometimes undisplaced fractures, which are very common in quite young people, post-trauma, cannot be detected on plain X-ray, and a tenderness on the GT should arouse the suspicion of an undisplaced greater tuberosity fracture or a rotator cuff tear. So, you should, when there is tenderness on the greater tuberosity, you should rule out these two pathologies by further investigations. And tenderness in the bicipital groove can happen due to a biceps tenosynovitis or a partial tear or full tear of the biceps, longitor biceps. And then spine of scapula, tenderness can be due to kind of fracture, etc. And again, tenderness on the vertebral border of scapula can happen due to tears of the rhomboids major or rhomboids minor muscles, etc., which is less common but can happen due to trauma during sporting activity. So, when you want to palpate the coracoid, it is better that you stand behind the patient and then try to poke your finger deep between the pectoralis major and deltoid in the upper part of the deltopectoral triangle. That's where you should try to feel the coracoid. It is not very difficult in thinner individuals, but can be slightly difficult in obese individuals. But if you can identify the deltopectoral triangle and you try to palpate in the upper part of the deltopectoral triangle, you can easily palpate the coracoid. And palpation of the acromioclavicular articulation. Try to palpate the clavicle slowly till its lateral end, and then you reach the acromioclavicular joint. And then once you reach the acromioclavicular joint, try to feel, assess for the tenderness at that point. And also, you try to ask the patient to flex and extend the shoulder and cross-adduct the shoulder to check for the movements of the acromioclavicular joint, and then to be sure that you are exactly like the acromioclavicular articulation. Acromioclavicular articulation, there is one more test as I told you, the cross-body adduction test or scarf test, what you call. You bring the patient's arm into 90 degrees of forward flexion, elbow flexed onto the opposite shoulder, and do the similar thing on both the sides. So, patient complains of pain with this maneuver, then this usually indicates a pathology in the acromioclavicular articulation. Coming to palpation of the greater tuberosity, just go a little bit below from the anterolateral tip of the acromion and inferiorly, slightly inferiorly, with the arm in slight extension and slight internal and external rotation maneuver, you can feel the greater tuberosity. And if you can palpate there, you can feel for the tenderness of the greater tuberosity. Now, coming to the palpation of bicipital groove, the bicipital groove is located anteriorly, medial to the greater tuberosity, and is bordered medially by the lesser tuberosity. External rotation of the arm brings the bicipital groove and makes it easier for us to palpate. The spine of the scapula can be palpated from behind the patient, and usually it is at upper 1/5 of the scapula and ends in a flat and smooth triangle. And tenderness at this spot can be assessed, and it could be due to some fractures or it could be due to some kind of muscle tears which are adjacent to the spine of the scapula. Coming to the movements, range of movements, you should look for total flexion and total extension of the patient, and external rotation should be assessed with the arm by the side and with the arm abducted 90 degree. So, external rotation by the side and external rotation with the arm abducted this way. So, both kind of movements should be assessed. Coming to internal rotation, again with the arm by the side and with arm abducted 90 degree. So, both these movements should be assessed. And abduction and adduction, all these 6 movements should be assessed and to be documented in the case sheet. Now, when you examine for range of motion, we should check for active movements first and then look for passive range of motion. Testing for the range of motion, it should be broken into a glenohumeral joint movement and scapulothoracic movement and combined range of motion. Shoulder examination, when you flex, the flexion is up to 120 degree and extension usually up to 45 degree. You should cup your hand over the acromion and stabilize the scapula. In this way, you are preventing the scapulothoracic movement and checking the flexion that is happening only at the glenohumeral joint. So, if you hold your hand on the shoulder and on the top of the shoulder and cup the shoulder with your hand, you will prevent the scapulothoracic movement and allow only the glenohumeral joint to move. And in this way, you can assess the total range of motion in the glenohumeral joint. So, usually this is 120 degree in forward flexion and extension is normally 45 degree posteriorly. Now, abduction again is 180 degree. Again, it happens, as I told you, happens at a rate of 2:1 ratio. Every 3 degrees of abduction, 2 degrees occur at the glenohumeral joint and 1 degree occur at the scapulothoracic articulation. So, check for active abduction and active forward flexion. And then check for passive abduction and passive forward elevation. So, it is important that you check for both active movements and passive movements. Adduction, move the patient's arm across the front of the body, is called cross body adduction, and check for the angle. Usually it is around 45 degree. It's cross body adduction. It can be done in supine position or in standing position. Now, action rotation, as I told you, rotation should be assessed both with the arm by the side and then arm at 90 degree abduction. So, arm by the side, you can ask the patient to action rotate the arm actively and look for active action rotation, and then you can repeat the same passively and look for the passive action rotation. Again, similarly, you can ask the patient to bring the arm into 90 degree abduction and then ask him to action rotate and look for active action rotation at the arm by 90 degree. And again, you can check passively by doing passive action rotation in 90 degree abduction. So, action rotation while lying on the couch will stabilize the scapula, and then this will only allow you to assess the rotations that are happening at the glenohumeral joint. Initially at the 90 degree abduction, and now by the arm by the side you are examining the action rotation. So, all these range of motions should be documented in the file. Again, action rotation while standing, where the scapula is mobile, again you can examine this. Coming to internal rotation again will be checked with the arm by the side in the front side, in the front of the body, and internal rotation reaching the back, where you will assess the number of spinous processes that the upper part of thumb can reach. And again, internal rotation with 90 degree abduction, we can assess what are the range of motion, what are the angle that is making with the bed. Usually it is around 55 degree, and then with the patient standing, and again you can do the similar examination with the patient lying down on the couch, which will stabilize the scapula. Similarly, we should examine internal rotation on the back, checking for the number of spinous processes that the thumb is able to reach. And you can note down, like you can note down lumbosacral junction, you can note down L3, you can note down D7, something like that. So, and you can compare with the opposite side, how much loss of internal rotation happened to this particular patient. Coming to the muscle testing, we should check for flexion, extension, abduction, internal rotation, external rotation, scapular elevation, scapular retraction, and scapular protraction. These are the various muscles which will assess in the shoulder. So, flexion, the primary muscles that are being tested are anterior portion of deltoid, coracobrachialis muscles, and secondary flexors are pectoralis major and biceps. So, you try to ask the patient to move the arm into forward elevation and try to resist it, and you are checking for the strength of the flexion. And extension, primary extensors are latissimus dorsi aided by teres major and posterior part of the deltoid, and secondary extensors are teres minor and then triceps. So, try to check for the strength and the extension of the arm. Abduction, primary abductors are middle portion of the deltoid and assisted by supraspinatus, and secondary abductors are anterior portion of deltoid and serratus anterior. So, look for strength of the patient in abduction. Adduction, primary adductors are pectoralis major and latissimus dorsi, and secondary adductors are teres major and anterior portion of the deltoid. Check for the strength of the patient's adduction. Axial rotation, primary axial rotators are infraspinatus and then teres minor, and secondary axial rotations for posterior portion of the deltoid. So, arm by the side, we check for axial rotators. And internal rotation, the primary internal rotator is subscapularis and then pectoralis major and then latissimus dorsi and teres major. Coming to the strength of internal rotations testing, the primary internal rotators for subscapularis and pectoralis major and latissimus dorsi and teres major. Whereas the second internal rotator is an anterior portion of the deltoid. So check for the strength of the patient in internal rotation. Coming to the scapular elevators, what we call the shrug test. Ask the patient to elevate the shoulder, both the shoulders, and try to just push them down. And usually this is the primary elevator is the trapezius, and this is supplied with spinal axis nerve. So usually in lesions of spinal axis nerve, the trapezius palsy, the patient cannot do the shrug test. And the assisted by this primary elevator of trapezius, the primary elevator trapezius is assisted by levator scapula. And second elevator is rhomboids major and rhomboids minor. Coming to scapular retraction, what we call attention position, that like where the military say when they say attention, so you keep your body and scapula retracted, it's called attention position. The primary retractors of the shoulder are rhomboids major and rhomboids minor and assisted by the trapezius. Scapular protraction is called reaching position, wherein you try to reach for something with both your hands. It's called a reaching position, and in which we do the scapular protraction. The primary protractor of the shoulder is serratus anterior. Coming to rotator cuff examination, we know that the rotator cuff unit is comprised by subscapularis anteriorly, supraspinatus on the top, and infraspinatus teres minor posteriorly. Now, when you evaluate rotator cuff, supraspinatus, we check for supraspinatus, infraspinatus, subscapularis, and then teres minor. So, supraspinatus, you have to keep the arm abduct in the plane of the scapula, and then it is internally rotated with the thumb down, what you call the empty can sign, and then ask the patient to elevate and resist this movement with your hand, and try to see for pain while doing this maneuver, and also try to see for weakness while doing this. So, if there is only pain, it could be an impingement, simple cervical impingement, or it could be some kind of partial tear. If you can establish definite weakness, not just because of pain, but definite weakness, probably you are dealing with a full thickness tear or a large tear of the rotator cuff. Coming to infraspinatus, you examine the external rotation with the arm by the side, resist the external rotation, and then you can evaluate for the infraspinatus. Coming to subscapularis, resisted internal rotation and with the arm by the side can be checked. Again, lift off test with arm behind the back of the patient, and Napoleon test and bear hug sign again can be tested. So, I am going to show you the various rotator cuff examination tests here. So, I am checking for the empty can sign, assessing the supraspinatus. The arm is kept in the scapular plane, or arm is elevated in the scapular plane, and the patient is asked to point his thumb downwards towards the floor, and then I will ask the patient to elevate both the arms against my resistance, and then I will assess for pain and I also assess for the weakness of the particular arm, and comparing both sides at the same time. In this video, you can see that the left arm you can resist my strength, but on the right side you cannot resist my strength. You cannot elevate the arm anymore. You cannot elevate the arm further. So this indicates that there is some weakness of the right arm or right shoulder. Coming to checking of the infraspinatus, I am checking resisted external rotation with the arm by the side. So I will ask the patient to keep the elbows by this by side of his body, and I will ask him to externally rotate the arm. And at the same time, I would like to exert resistance with my hands and try to oppose his movement. You watch carefully. I will keep his elbow close to the body. I will ask him not to lift the elbow away from his body. At the same time, I will ask him to externally rotate the arm by the side, and I will resist the external rotation with my arm. So you can see in this particular patient, the external rotation on the right is weak, the strength of the external rotation is weak compared to the left side. So this could give us an idea that the infraspinatus on the right side could be torn. Now I am going to examine the external rotation strength with arm at 90-degree abduction. So I will bring the arm into 90-degree abduction and I will ask the patient to actively external rotate his forearm posteriorly, and all the while I will try to exert a resistive force with my finger or hand and assess his strength. First I will do this test on the normal side and then I will repeat the same test on the affected side. So this is again checking for the external rotated strength, and this test usually what we call as Hornblower sign is very important to test the teres minor. And then we do something called the external rotation lag sign, wherein I ask the patient to keep the arm in adduction position with the elbow by the side of the body, and I will take the patient's arm passively into an external rotated position and maximum external rotated position, and then I will just leave it there. If the patient can maintain that position, that means there is no lag. Say if the patient cannot maintain this position and the arm falls back onto his belly, that means there is lag in the external rotation, the arm cannot be maintained in external rotation and then it falls back onto his body. Usually it indicates a massive infraspinatus tear, and most of the times associated with the fracture degeneration. This is a prognostic value, this external rotation lag sign. This prognostic value is that most of the times we are dealing with something massive rotator cuff tear which may not be reparable. So we are dealing with an irreparable rotator cuff tear. Then coming to subscapularis, I am checking for the bear hug test, wherein we bring the arm to the forward flexion position and ask the patient to raise the opposite shoulder with the hand, all the while resisting his movement. So if you can resist my hand and then can bring his arm into rotation, usually it is negative test for subscapularis. If you cannot do that bear hug test and you cannot resist my force, usually there is a possibility of a subscapular tear which is there. And the second test I do is the Napoleon test, wherein I will ask the patient to keep his fingers crossed and crossed with the hands in the front of the abdomen, and then try to bring the elbows to the front or from the coronal plane of his body forward to the forward direction. And while the patient is doing this movement, I will resist these elbows with my hand. And if the patient can bring his forearm away from the coronal plane of the body, or he can resist my strength, then probably there is no subscap tear. This is called Napoleon test. And the third test we do for subscapular is called lift of lag test, wherein we will ask the patient to keep his hands behind his back and try to lift his hands away from his buttocks. If the patient can do it actively and he can maintain that position, probably the subscap is intact. We see here on the left, the patient, on the right, he can lift his hand off from the back and he can elevate it. On the right, he cannot, on the left, he cannot do the same. He cannot lift it off. And while exerting the force with my hand, he can resist me on the right side, but he could not resist me on the left side. So this indicates there is a possibility of subscapularis tear. Though there is no specific test for subscapularis, all these three tests together will give us an idea about the possibility of a subscapularis tear. So first one is the bear hug test, the second one is the lift off leg test. Sorry, the first one is the bear hug test, the second one is the Napoleon test, and third one is a lift off leg test. Repeat it in the video. Coming to the evaluation of rotator cuff, we should look for any signs of impingement and the possibility of partial tears and the probability of complete tears in the shoulder by clinical examination. Though it is the test cannot be precisely tell you what is just an impingement, what is a partial tear, what is a complete tear, but we can put together all the tests together and probably we can have a conclusion that something could be a complete tear, that could something be a partial tear. Sometimes there is overlap in the clinical signs and it may not be possible for us to precisely diagnose, make a differentiation between these two conditions. So, as you know, rotator cuff impingement syndrome is nothing but age-related degenerative changes in the rotator cuff tendons, which usually starts above 40 years of age and keeps progressing with age, wherein it starts with tendinosis of the supraspinatus, then followed by partial tear, sometimes a full thickness tear, to begin with small tears, and sometimes it can become a large tear. This is primary impingement is due to the age-related degeneration of the rotator cuff. Sometimes we have what we call a secondary impingement, wherein this is secondary to change in mechanics of the shoulder, like in unstable shoulders or due to overuse. This happens in sports persons and happens due to something called a GIRD or a posterior capsular tightness syndrome, wherein the tightening of the posterior capsule will lead to secondary impingement of the supraspinatus tendon. Is called overuse injury. And then sometimes due to trauma can lead to rotator cuff dysfunction or rotator cuff tear, and this also can give you impingement. So this is a secondary impingement, whereas primary impingement is due to gradual degeneration of the rotator cuff tendons and muscles with age. So the diagnosed tests are Neer's impingement sign, Hawkins test, and Neer's impingement test. Neer's impingement test is the patient arm is internally rotated and the examiner should stand behind the patient and he try to elevate the arm with the arm in internal rotation, and the patient complains of pain while doing this maneuver. Usually we can say that there is some impingement in the subacromial space. Again, Hawkins test for rotator impingement, the patient's shoulder is flexed to forward flexed to 90 degree and elbow flexed to 90 degree. The examiner grabs and supports the proximal part of the patient's wrist and to ensure maximal relaxation, and then quickly rotate the patient's arm internally. And if this internal rotation gives you pain, then we call it as a positive Kennedy Hawkins test. So forward flex 90 degree, flex the elbow 90 degree, and then quickly internal rotate the arm, and a positive test gives you pain. It's called Hawkins test. Coming to drop arm sign, try to abduct the arm of the patient passively 90 degree while supporting the arm at the elbow, and then you release the support of the elbow and ask the patient to lower slowly. If there is a sudden drop of the arm and that the patient cannot control the arm and the arm drops suddenly, it's called a drop arm sign. Or if there is weakness in maintaining the arm position also, it's a sign of a massive or a large rotator cuff tear. It's called a drop arm sign. Here we see in the picture, you bring the arm to 90 degree position, supporting the arm and forearm and elbow, and then when you leave it and ask the patient to hold the arm in that position, if you cannot hold it the position and then the arm drops down, it's called drop arm sign. Coming to the instability test, the first test we look forward is in the sulcus test, which will usually indicate kind of multidirectional instability, wherein you ask the patient, you keep the arm close to the body in adduct position, and then you flex the elbow to 90 degree and exert an axial pressure on the arm and look for any dip between the acromion and the humeral head. It's called sulcus test, and the test is positive when the subacromial space opens up more than 1 centimeter. So then what we call is a positive sulcus test. If less than 1 centimeter of gap between the humeral head and the acromion, lateral border of acromion, this is not positive. It is more than 1 centimeter, we call it as a positive sulcus test. Here you can see the arm is adducted and then the elbow is flexed 90 degree and I am holding at the elbow and giving an axial pressure, pulling the humeral head down. And this maneuver, if it opens up the subarachnoid space and you can see a sulcus just below the acromion, then you call it sulcus positive, but if it's more than 1 centimeter, it is clinically relevant. Coming to anterior instability test, the first and most important test is the anterior apprehension test, wherein you stand behind the patient, keep the arm 90 degree abduction and 90 degree erection rotation and try to anteriorly bring the arm into the extension, and this creates a kind of fear of dislocation in the patient, sometimes also with pain and a click, what we call as an anterior apprehension test. So, sometimes the patient have pain in this position in other associated conditions like frozen shoulder or rotator cuff pathology, but this is not a confirmatory test for, then this cannot confirm that instability. The patient complains of fear of dislocation in this position, what we call the apprehensive position, in this 90 degree abduction and 90 degree extension rotation, then you should say that is a positive apprehension test or this is a positive test for anterior apprehension or anterior instability. The apprehension test can be repeated with the patient lying down on the bed, in this just like shown in this video, wherein you bring the arm to 90 degree abduction with the arm into 90 degree extension rotation, and in this position the patient complains that he has a fear of dislocation, and then you support the arm and pushes it posteriorly, then the fear of dislocation goes away. The similar test can be done with arm, with the patient standing. You can bring the arm to 90 degree abduction with 90 degree extension rotation, and in this position try to accelerate it more and bring the arm into extension. The patient complains of a fear of dislocation. Now, something called load and shift test. For this, the patient is better seated, and then we have stabilized the scapula by cupping the upper part of the scapula with our one hand, and with the other hand we will hold the humeral head, and then we push the humeral head onto the glenoid and try to push the head, try to sublux the head anteriorly and posteriorly, and try to assess the amount of subluxation we can make and compare with the opposite side. If it is grade 0, there is no movement at all. If it is grade 1, there is slight movement, and if it is grade 2, it is half of the humeral head is subluxed, and grade 3, if the entire humeral head is subluxing. It's called load and shift test. We see here, I hold the humeral head and then push the humeral head onto the glenoid, that means exerting an axial compression of the humeral head onto the glenoid and try to shift it anteriorly, and then check for the amount of subluxation of the humeral head. Again, for checking the posterior instability, the one important test what we do is the jerk test. Here you stabilize the scapula of the patient with one hand and hold the affected arm at 90 degree abduction and ankle rotation, and grasp the elbow and axially load the humerus in a proximal direction, and the arm is moved horizontally across the body. A sudden clutch indicates that the humeral head has subluxed posteriorly and there is a posterior labral tear, and then the patient complains of pain, and then once you bring back the arm to the neutral position, then the humeral head gets reduced and the pain goes away. This is called a jerk test. You can see here the arm is adducted across the body with the elbow flexed at 90 degree, and then the scapula is stabilized with one hand and while exerting axial force along the arm. And if there is a sudden jerk in the joint and there is a clunk that can be felt and the patient complains of pain, the jerk test is positive. This indicates a posterior labral tear. The next test is a push-pull test, wherein you keep the patient supine on the bed to stabilize the scapula and keep the arm in 90 degree abduction and keep the elbow at 90 degree flexion, and then on the forearm pull it superiorly towards the ceiling while exerting posterior directed force on the arm. So, you are pulling the arm upwards here, and then you are pulling the forearm upwards, you are pushing the forearm downwards in this direction. So, it's called a push-pull test. You are pulling the forearm and pushing the arm down, and this again, if there is pain and a kind of click in this position, it usually indicates a kind of posterior instability. Here the video to demonstrate this push-pull test. So, keep the arm at 90 degree flexion, 90 degree abduction with the elbow being 90-degree flexion. Push the arm downwards, pull the forearm upwards. This is called push-pull test. Slap lesions, what we call as the superior labrum, anteroposterior lesions. The injuries to the glenoid labrum. They involve the superior glenoid labrum where the long head of biceps tendon inserts. Sometimes the superior labral tear can extend to the long head of biceps also. If it is involving less than 50% of the long head of biceps, what we call as a type 3 slap. If it involves more than 50% of the long head of biceps tendon, that is called type 4 slap. Now, this usually happens in sports, but it can happen in other kinds of injuries also. It can happen due to fall on outstretched hand, and then it can happen due to overhead throwing, wherein what we call the overuse syndromes, wherein you put a lot of stress on the shoulder and do a lot of overhead throwing like baseball pitchers, or it could be tennis players, or it could be basketball players, etc., or volleyball players. And usually in these patients, you should look for some kind of posterior capsular tightness, which usually leads to the slap tear over a period of time. The posterior capsular tightness, or GIRD, what we call as glenohumeral internal rotation deficit, is the primary reason which changes the biomechanics of the shoulder in overhead throwing and gradually causes slap tear, what we call as internal impingement syndrome. And this can also be associated with a partial articular side tear of the supraspinatus also. And again, hyperextenotation in abduction also can lead to slap tear. There are various mechanisms a superior labrum can be torn. To diagnose slap clinically is not easy. In fact, a diagnosis of slap needs clinical examination, history, including the mechanism of injury and the symptoms of the patient, and then clinical examination findings, and then radiological findings. So, and finally, this should be confirmed by doing arthroscopy if you are subjecting the patient for further treatment. So, what we call it as a clinico-radiological arthroscopy correlation, you can only diagnose a slap comfortably in most of the cases. Though, in certain severe cases of type 3 slap, type 4 slap, it can be easy to be picked up in an MRI scan. MRI scan alone cannot give you a diagnosis of slap. You should be substantiated by clinical examination, and also finally arthroscopic correlation is necessary to diagnose a slap. Now, there are certain tests for slap. The sensitive test is O'Brien's test, and passive distraction test, and compression rotation test. And specific tests include Speed's test, Ergasson's test, biceps load test. Ergasson's test, you keep the elbow flexed to the 90-degree, keep the arm adducted, and then you ask the patient to extend rotate the forearm, that means supinate it, while you try to force it into pronation. This is called Ergasson's test. The Ergasson test is positive. It could be due to a pathology of long head of biceps, or it could be due to slap tear also. You can see the Ergasson's test here in this video. You hold the arm at the elbow and stabilize it, while you ask the patient to supinate his forearm, and you resist the supination and try to rotate into pronation. So, if the patient can resist your force and can supinate the arm, if the Ergasson's test is negative. If you cannot supinate the arm and the complaints of pain in the bicipital groove region, then it is a positive Ergasson's test. This could be due to a pathology of the long head of biceps, or this could be due to a pathology of the superior labrum. Coming to slap lesions and biceps evaluation, something called Speed's test, wherein you keep the arm in complete supination with elbow extended, full elbow extension, and forearm in supination, and the shoulders in external rotation, and ask the patient to elevate the arm in this position, and you resist the forward elevation with your strength, with your hand. And the patient complains of pain in the bicipital groove with this maneuver is called a positive Speed's test. This again indicates some pathology of the biceps, long head of biceps, or superior labrum. And a biceps load test is wherein you make the patient supine on a couch with the shoulder and bring the shoulder into 120 degree of abduction, elevation, and full external rotation with the elbow 90-degree flexion and the forearm in supination. So, bring the shoulder into 120-degree elevation, elbow 90-degree flexion, ask the patient to flex the forearm or elbow against your resistance, and look for any pain and weakness during this maneuver. Coming to O'Brien's test for slap lesion, which is a sensitive test, keep the arm bring the arm to 90 degree elevation with the thumb down and ask the patient to elevate the arm, and while you resist this with your hand, and the patient has pain, then ask the patient to keep the thumb up with external position and repeat the maneuver. The patient has no pain, the patient has pain in the thumb down position and the patient has no pain in thumb up position, then you can consider the O'Brien's test and you should suspect a slap lesion in this kind of patient. And again, you have to check for the sensation on the lateral part of the deltoid. This is to check for the axial nerve, which is the C5 nerve root, and loss of sensation in this particular area or regimental bad sign, what we call it as, where the loss of sensation in the lower deltoid region can indicate an injury to the axial nerve. And then we should look for thoracic outlet syndrome by doing Adson's test. In this position, the patient is seated in a position, in a seated position, arm is abducted to 30 degree and maximally extended, and radial pulse is palpated while the examiner extends the patient's neck and turns the head towards the symptomatic shoulder, and the patient is asked to take a deep breath and hold it. The quality of the radial pulse is evaluated and compared to the pulse taken while the arm is at resting. Test is positive, there is a marked decrease or disappearance of the radial pulse during this maneuver. The test should be done on both sides for comparison. So this usually indicates some kind of compression in the thoracic outlet. So this test is done along with neck examination to rule out pathologies which are away from the glenohumeral joint. And like any other joint examination, the examination is not complete without examining the sensory motor examination and distal pulses, palpating the distal pulses. So examination of the motor and sensory motor power of the elbow and forearm and hand, and again look for any sensory disturbances of the arm, forearm and hand, and the distal radial pulses to be palpated. And in this particular test, I would like to emphasize there is a condition called Parsonage-Turner syndrome or brachial neuritis. This closely mimics rotator cuff tear, where the patient can complain severe pain on the neck and arm and all that, and he can develop sudden weakness of elevating the shoulder. But when examine these patients carefully, they will have some associated weakness of the elbow, flexion and extension, and rarely the weakness can extend into the fingers also. So if you don't examine this distal neurovascular, don't do this distal neurological examination, you will think this is a rotator cuff tear. And this is one important point where you have to differentiate this neurological condition from a rotator cuff tear in these patients. And of course, there is one more important point. Usually rotator cuff tear can happen due to trauma or can happen due to degenerative tears, and traumatic tears you can know, and degenerative tears can happen gradually or insidiously in onset. But whereas in Parsonage-Turner syndrome, it is sudden in onset without trauma. That's one important point which you should look into when examining these patients. So somebody has sudden weakness of lifting the arm or shoulder without trauma, and you should always keep in your mind, you should evaluate for distal neurovascular deficits by examining the brachial plexus, by examining not only the arm and also elbow and hand to rule out a brachial neuritis which involves multiple roots. And at the last, palpate the axilla for lymph nodes and check for these lymph nodes can indicate some kind of infection pathology in the glenohumeral joint. Thank you.